Hello, this is again Professor Nick and Nikov, or PA Nick from Brooklyn, New York. I would like to present to you and to your attention a preventive medicine chapter for PANP boards. Let's start from the first slide. There is so-called USPSTF, which is United States Preventive Services Task Force, which have the most reliable preventive medicine guidelines, which is the standard of care in this country. Also, we cannot forget several society and associations like American Cancer Society, American Urological Association, American Diabetic Association, and American Heart Association. There is a clinical tip which states that the mortality benefit in these guidelines is what to do, which of the following is the most likely beneficial for the patients. Let's start with cancer screening. Here there is a clinical vignette which is asking which cancer screening method lowers the mortality mostly. Which of the following is the most likely beneficial for the patient? Number A, pap smear. Number B, colonoscopy. Number C, prostate specific antigen or PSA. D, mammography above the age of 40. E, mammography above the age of 50. The right answer here is E, and the answer states that controversy may surround the question of how early to begin the mammography. Recommendation for right now to start mammography at age of 50, instead age of 40. There is a clinical tip here which states that the age to start mammography can be controversial between 40 and 50 years old. But the maximum benefit is after age of 50, and the benefit is clear. Let's talk about breast cancer. Mammography should be done starting age of 40 to 50 every 2 years. The reduction of mortality is the greatest above age of 50. Screening needs to stop at age of 75. There is a clinical tip here which states that breast self-examination is always the wrong answer, although it may seem to benefit it, but there is no proof. On average, you will detect 10 cases of breast cancer by screening 1,000 women above age of 50, but you're gonna detect only 2 cancers by screening 1,000 women between the age of 40 and 50. MRI, CT, ultrasound do not have a clear place in the terms of screening for breast cancer. As a screening tool, only mammography has a proven to lower the mortality. Let's go to the next slide, slide 3. This slide, there is a clinical vignette in the beginning, which is asking which of the following is the most likely to benefit an asymptomatic patient with multiple first-degree relative with breast cancer. A. Tamoxifen or ravoxifen. B. BRCA testing. C. Aromatase inhibitor such as anastrozole or letrozole. D. Dietary modification such as low-fat and soy diet. E. HER-2 neurotesting, and F. Estrogen or progesterone receptor testing. The right answer here is A. Both selective estrogen receptors modulator, so-called SERMs, such as tamoxifen and ravoxifen, result in 50 to 66 reduction of the breast cancer when compared with placebo. The benefit is great in the second, first-degree relatives with breast cancer, mother and sister. SERMs are amazingly underutilized in prevention of breast cancer. Let's talk about so-called BRCA testing. BRCA testing is associated with increased risk of breast and ovarian cancer. This does not mean that there is no clearly beneficial screening test. The missing piece here is what to do when the patient is positive for BRCA. It is not clear. It's the only true unambiguous statement about the BRCA testing is that there is a positive test, means an increased risk of cancer. The management remains undetermined. There is a clinical tip here which states that when BRCA is positive, often prophylactic bilateral mastectomy is the wrong answer. Wow. Let's talk about cervical cancer screening. There is a clinical tip here which states that pap smear is done from age of 21 for 65 years old. Now let's go to the next slide. Slide number 4. The first pap smear is done by age 21. Pap every 3 years, age of 21 to 30. Pap smear definitively lowers the mortality. Say, for example, between 7,000 and 10,000 cases of cervical cancer per year, only 185,000 cases of breast cancer. Pap smear is not near as beneficial as mammography. Pap smear is done every 3 years. Papilloma vaccine is a routine for all women between age of 11 and 26. Combine PAP and HPV testing between the age of 30 and 65 stretches the interval to 5 years. Adding HPV testing to PAP increases the interval to 5 years. There is a so-called colon cancer screening. Chlamydia screen women between age of 15 and 25 years old. There is a clinical vignette here, but before that, let's talk about the lifetime risk of colon cancer for an American is between 6 and 8%. Each year, 50,000 people die from colon cancer in the United States. 95% of these deaths are preventable with screening. So the clinical vignette here is asking, what is the following is the most likely beneficial for the patient? A. Colonoscopy every 10 years. after age of 40. B, colonoscopy every 10 years after age of 50. C, sigmoidoscopy every 3 to 5 years after age of 50. D, barium enema after age of 50. And E, fecal occult blood testing. Let's go to the once again, for the most important here for prostate cancer screening, there is no clear beneficial test which lower the mortality of prostate cancer screening. There is no benefit of PSA, and of the patient with prostatic CA, 25% have normal PSA, and 25 of those which has elevated PSA do not have cancer. These conditions are so-called, this is slide number 11. Number one, asplenia, which is no spleen. Number two, terminal complement deficiency in those getting eculizumab. Number three, military recruits. Number four, residents in college dormitories. And number five, travelers to Mecca or Medina in Saudi Arabia. Let's discuss tetanus. Never vaccinated, they get immunoglobulin. Dirty wounds, booster after 5 years. Clean wounds, booster after 10 years. There is a clinical vignette here which is asking which of the following is the strongest indication for meningococcal vaccination. Example, who will be the benefit mostly? A. Asplenia. B. Military recruits. C. Residents of college dormitory. D. Travelers to Mecca or Medina. And E. 11 years old child. The right answer here is A. Asplenia represents a person with high risk of disseminated meningococcal infection. And that's why A is the right answer. The end of this slide discusses osteoporosis. Let's talk about it. Every woman should be screened with bone densitometry at age of 65 with DEXA scan. Hip fracture in elderly patients carry an extreme high risk of mortality. Preventing fracture with biphosphonate to increase the bone density is potentially more life-saving than beta blocker in coronary artery disease. A hip fracture is more deadly than MI. Let's go to the next slide, slide number 12. Here, we'll start this slide talking about abdominal aortic aneurysm. All men of age of 65 with smoking history should be screened with ultrasound to exclude aneurysm. Aortic abdominal aneurysm or AAA should be repaired if it is wider than 5 centimeters. Also screen 65 to 75 with family history of AAA. There is so-called smoking cessation. All patients should be asked 5 questions. Be asked, do you smoke? Be advised, stop smoking. 3, attempt, find out who really wants to stop. 4, be assisted, prescribe a method of aiding nicotine dependency. And number 5, arrange to meet with patient again and find out if they have a set of white which quit date and have really managed to stop. Let's talk about intimate partner violence or domestic violence. We need to remember that all patients should be asked about possibility of domestic violence or intimate partner violence. Patient will most often not volunteer all this information. You cannot report this form of injury without a consent of the patient. Let's discuss so-called alcoholism or alcohol dependency. Alcoholism is self-diagnosed disease. Alcoholism is not defined, as an amount of alcohol use. It is not defined an alcohol use leading to loss of employment. Many alcoholics still maintain their jobs. And let's go to slide number 13, the last slide. We need to ask the patient so-called cage questions. C, A, G, E. C, do they feel the need to cut down the amount they drink? A, do they feel angry when asked about their drinking? G, do they feel guilty about the amount they drink? E, do they need the amount of the morning eye opener? So the cage questions are excellent in helping patients recognize if they are alcoholic dependent. Also, there is a so-called routine screening. So routine screening methods which are always incorrect. This is chest X-ray, EKG, stress testing, and they are never correct as a screening methods for the healthy general population. And this is the end of the lecture. Thank you so much for your attention. If you have any questions or suggestions, please feel free to email me. My email is very simple, NICK, M like Mary, D like dog, the number 1 at gmail.com. Thank you.